In the meantime, we'll get back to Kishore and maybe ask him a few questions. We seem to be having some issues with the Zoom recording, because I think a few people have been mentioning that they were getting logged out repeatedly. So I'll just check with Sandeep and Neeraj. Neeraj, are we back on again, or is there a problem still?
Neeraj is muted.
Yeah. So I don't know who else is there. Is Dhiren, Sandeep?
Oh, I'm here, Alaric.
Alaric,
Yes.
Alaric,
Yes,
yeah,
Dhiren.
already the recording is going on. So don't worry, we will be able to transmit it later on also. So please continue the webinar.
All right.
We
Okay.
will be, yeah.
So I think Kishore and Bodhbhav, there's been some technical issues, and a couple of minutes I think we have logged out from the main group. But as Dhiren says, we are recording all of this, and it will be up on the website, so we can still continue with the discussion and with the cases. We have about 10 minutes to go. So if there are any questions that the other panelists have, or we can go on the cases directly. Yes, Ramni.
Yeah, it was a very interesting presentations, both Kishore and Shankar. So I have a few questions, Alaric, if you permit me.
Yeah,
so,
sure.
Kishore, in the course of your presentation, I had this impression that in irreducible hips, if once you have started off on a Pavlik harness, then you switch over to the rigid braces and do not consider close reduction at some point of time. So my question to you is that what is your threshold to switch over to close reduction?
Yeah, so I said, Ramani, for me personally, that approach of switching to a more rigid brace has not worked. And the case that I showed is one of my colleagues. Okay. So I start with a Pavlik harness. And if that's not successful, I have tried. And sometimes I still do. I tell the family, look, I don't know if this will work. I'm happy to try. And I leave it to the families to decide which way they would go. But the families have said, yeah, they would try more rigid brace, because as we've seen in my presentation, there are people that do switch over or actually start with the rigid brace and claim that they have a better success rate. So I switch over to a closed reduction as early as 2 months if the families agree, knowing the anesthesia risk. But majority do. And so I do somewhere wherever I can actually have access to them. But the ones that don't, and I do them at 4 months of age, anytime after 4 to 6 months, whenever I can get the family to come in to have that. Because if the close doesn't work, then the anatomy is hopefully big enough for me, at least, that I can appreciate that I can go on to an open reduction.
Okay, 2 more questions to you. One is, what are your views on that gradual reduction by Pavlik harness beyond, in the early infancy? That is one. And what is your the threshold for switching over from closed to open? What is the general age when you switch over from closed to open?
So I would always, when I trained with people like you, and you honestly, you have way more experience than I do in this, and you do a lot more numbers than we do. So when I worked with, Dr. Benjamin Joseph, my experience, and which I carried on to early part of my practice, which I would do closed reductions up to 2.5 years of age. And that's it. I would do nothing else at that point in time, if they worked. So I would always try closed reduction. But I must say that age has come down. And when I started appreciating, if in doubt, it's out. In other ways, I have actually probably forced a lot of closed reductions, which I don't do now. If in doubt, it's out. If it's out, do an open reduction. And for me, I have a low threshold for doing an open reduction, because I think a forceful closed reduction, even though I love the Swiss watch analogy, and that's the beauty of our registry, is that we have so many different ways that we all go with. And I do an open reduction. So I have a very low threshold, because when you look at, again, preliminary results, the AVN rate actually in our closed reduction group is slightly more than our open reduction group. So they're not significantly more. But what we don't know is what Woody is alluding to. What does that mean 10, 20, 30 years from now? Are we going to see more growth disturbances because of open reduction? We don't know that. But I have a low threshold. So I'd say roughly 12 months and up, I am really looking at, in fact, if I see someone at 12, I almost now wait till 18 months and I do everything at once, close reduction, open, and possibly a pelvic osteotomy.
Well, I don't do closed reductions. I'm actually doing more of open reductions beyond 10 months of age, because I actually believe what you just said, that beyond 10 months, okay, let us keep it as 1 year. Once you start believing that you are actually achieving closed reductions beyond 1 year of age, you are subconsciously actually forcing that hip inside. So I switch over this question to Shankar. Your presentation was pretty extensive and very, very well covered. My question to you is, what is your threshold to switch over to open reduction? I mean, that is the question right now.
Yeah, so thank you. I think it's a great question, and I think that's the art, and that's what makes this, such an interesting disease process to treat. And I believe, as I do, strongly in closed reduction, but you don't see the denominator, right? You don't see the patients that I opened, and I do far more by numbers. I do far more open reductions than I do closed reductions. So I would say, just roughly off the top of my head, I would say probably if I go to the OR, probably 2/3 of my patients in this 7 to 14 month age group, probably 2/3 get opened and maybe 1/3 are closed. But, really I really care about the arthrogram. So I know a lot of centers don't use arthrograms. To me, it's like flying blind. I don't know how I could make an interpretation based on a radiograph. I'm fascinated with arthrograms. I find them so interesting, and I kind of scrutinize all the detail, and my fellows will spend 10 minutes looking at the arthrogram, intraoperatively. But to me, I ask myself the question, and the Colin Mosley trained me, among other people, and he was not a big closed reduction or a medial open reduction person. He didn't do a lot of arthrograms, and he would always ask, are you going to make this hip better? And if you're not going to make the hip better by opening the hip, then don't necessarily open the hip. So to me, I look at, what am I getting out of the way? Is that femoral head as medialized as it possibly can be? Or is there something obstructing it? Not inferiorly, but if the most medial aspect of the head at the superior medial aspect of the acetabulum is at contact, I can't get that hip anymore in. So assuming I'm not pushing hard and I'm not, I don't feel tension. If I don't feel tension, and I feel like that hip is as in as it's going to be, to me, my kid, I wouldn't want to make an incision and inflict harm just based on a number being an age.
Great.
Thank you.
Woody. I have a question now for both Kishore and Woody. I think Kishore alluded to this in his talk, that there is a school of thought which talks of waiting for the ossific nucleus to appear before you do a closed or an open reduction. And I think Nick Clark feels very strongly about that. About the protective influence of the so-called ossific nucleus. So in your practice, what's your thought on this? And why has this thing even come about? Why do people even think that way?
So, I would say this is the power of numbers. And this is the power of a strong, very thoughtful people like Dr. Clark or Mr. Clark, whoever we want to call. Nick is an amazing guy who contributed a lot to understanding of DDH, so I don't want to take away from his contributions. But if you look at his original study that's published, he had roughly 20 hips that had ossific nucleus that's present, 20 hips in the other group that did not have an ossific nucleus. Where the ossific nucleus was absent, there was 4 AVNs. In the other group, there were 2 AVNs. And so the conclusion is there is double the rate of 50% increase in AVN rate in one group. And we all know when you have such small numbers, it could be from chance alone. So when Woody looked at it as a part of his closed reduction paper for IHDI, that did not hold good. In fact, as you could intuitively think about it, the older the child, the more the risk of a AVN, and that's what we found. So in fact, ossific nucleus being present wasn't protective. And if you waited for the osteopic nucleus to appear, there may be a trend. Mind you, these are small numbers. Emily Schaefer, now a research director, is really looking at predictors of AVN. And I would be hard to think if osteopic nucleus would be a predictor that will stand the test of time. So personally for me, I do not wait. And I would recommend people not to wait, because we know the natural history is the earlier you get the hip in, the better chance of remodeling and the better chance of doing a gentle reduction versus forcing a reduction if you wait too long. But I'd be interested in Woody's comments.
Well, just for the purposes of time, I'll leave. I agree completely. I won't say much more than that. I thought you were going to ask me about the waiting till 18 months for the pelvic osteotomy, because I think that's a very hot topic, I think, in our world right now. I thought that was going to be your question about timing, which I could answer since I asked the question myself. But if you have another question, I'll let you go.
Yeah, why don't you answer that?
Yeah, so I think a lot of people are saying this, in case Kishore mentioned it himself, and I mentioned a little bit in my talk. I think one of the things that I think is being overlooked in that argument is that we are measuring residual dysplasia on two-dimensional X-rays. And so we're doing a Salter or a Pemberton or whatever you like to do, and bending it down or cutting it and rouging it over and making a two-dimensional metric of the Astadler index better, and then telling ourselves, wow, I really did great to halt residual dysplasia in this patient. And this completely disregards three-dimensional remodeling, right? Version and all these other aspects that I think are so important. And my opinion is you should really get to the hip early rather than waiting for it, because all those three-dimensional axial remodeling things that we're not quantifying very well can only be better by getting the hip in early, right? Because that's normal neonatal and infantile development. So to me, the fallacy of kind of the delay in 6 months, for example, some people will wait 6-7 months before they put a hip in because they're waiting for this magical 18-month number to do a pelvic osteotomy. First off, I think there's nothing magical at 18 months. It comes from Salter, and anybody who's done extrophy work, you can do a pelvic osteotomy on a 6-day-old if you need to. I mean, it certainly can be done. So I don't think there's anything magical at 18 months. But even more so, I would say I wouldn't wait on the hip, because there are three-dimensional remodeling effects that we are just blind to, that can only be better by getting the hip in early. So I don't wait. Even if I have to come back and do a pelvic osteotomy, I still feel like, I guess it's a little bit like my idea about closed reduction. I don't feel like that's a failure, because I feel like it still was better for the joint. Maybe it's a second anesthetic, fine. Maybe it's a second casting, fair enough. But I still think it's better for the joint.
We'll take a question from Vijay.
Yeah, I have a question for Woodbov. This is on your arthrogram.
Yeah.
You have a 7-month-old child you've taken to the OR and you've reduced the hip closed. It's stable, you do the arthrogram. And then you see a not so perfect arthrogram, like an increase in the medial pool or an inverted labrum. At 7 months of age, would you accept that, or would you do an open reduction?
No, I open the hip.
You open up
I would
every
open the
time,
hip, and then-
even though it's stable and it's not going out.
So this is the art, right? So to me, an infolded labrum, I'm not a fan of that. There are some studies that show that some of that will, including some studies that we've done, showing that it'll dock a little bit and the labrum will evert. I just don't like rolling the dice on that. I think if there's a little bit of a medial dipool, but no thick ligamentum teres, it's a few millimeters, but it's nicely concentric superiorly, that's the judgment call. But I am not, this is why I think it's a little bit skewed when I believe strongly in closed reductions, but I believe strongly in good closed reductions. And so if it's not a nice reduction, then I will open that hip.
Great. Thanks both of you. I'm quite sensitive to the time here, that we have already finished an hour and a half. And I don't see we have much time for the cases, but maybe if there's a couple of questions that we could take, that would be great. Ramni?
Yeah, Shankar, a couple of questions pertaining to, one is perfusion MRI. I see that you prefer perfusion MRIs. Is that because you are concerned about the AVN? Is that the reason, or that is one? And secondly, I want to know your threshold for performing femoral osteotomies below the age of 3 years, apart from the pelvic osteotomies, which probably is the first preference as a supplementary procedure.
Yeah. So, okay, those are all great questions. So perfusion MRI is a long topic. It's a little, in general, yes, the indication for the perfusion is theoretically to get some insight on the risk of osteonecrosis. And there's a study published from Boston where I trained that kind of started this whole idea. The problem is that there's a moderate correlation. So it's not a great correlation. And the other problem is that it's very subjective. So it's not like you get an answer. You see a decrease, and then how much is too much, and remember, it's a snapshot in time. What's the child's blood pressure at the time that they get the perfusion scan? So there's so many factors that make it slightly variable. That being said, in general, I think the idea, if we're going to get to no avascular necrosis, we have to start monitoring flow. And I'm working on some contrast enhanced ultrasound stuff, but the perfusion MRI is part of that package to really look at this. Again, lots of flaws associated with it, but that is the idea, so is to start working towards the answer to get rid of this 25% rate of osteonecrosis. We published a study at CORE showing that with this protocol, where we took the casts off if the hip was blacked out, we dropped our osteonecrosis rate to 4%, and we were pretty rigorous about the definition too. So I do think there is some help. The problem is that, it's hard. Radiologists say, oh, I'm not sure. And unless you're looking at a lot of MRIs and have something to fall back on, it can be very misleading. So I tell my fellows that I probably wouldn't do it in practice because it can obviously create more confusion sometimes. And you have to be willing to live in the gray world of the information that you get given. Now, your second question about femoral osteotomies, I never use femoral osteotomies. Like, I never perform varus as part of my osteotomy. I think, I try to avoid varus in general. In all hip operations I do, maybe Perthes is a slight exception, but in general, I try to avoid it. There's some interesting acute phase reactant data from Jonathan Schenecker showing that the physiologic effect of a femoral osteotomy is much more than a pelvic osteotomy as far as the hit on the body. And I think you guys, I'm sure everybody who's on this call has a lot of experience. Like, you do femoral osteotomies and you see that kids recover slower from that than they do from the pelvis. And I think that's my feeling as well. So in general, I only do it for shortening if it's tight, and that's just a feel, right? And that depends on how wide of a release you make, what your technique is. But obviously if it's tight, and again, that's such a hard thing to quantify, but yeah, I do if it's tight. And then if it's excessively anteverted. So if I really need to internally rotate the leg 70 degrees to get that neck to point directly at the acetabulum, I'm going to dial back a little bit of that rotation.
So what's
Great.
the
Thank you
youngest
so
patient
much.
you have done?
The youngest femoral osteotomy I've done? Probably
Yeah.
18 months. I don't think I've done much money under that. I mean,
Great.
I said there's good data about the remodeling of anteversion. And so if you can get, I don't chase excessive anteversion in a 12-month-old, but yeah, I mean, 18 months, 2 years. Yeah, I mean, I start doing it if it needs it.
Great. Thank you so much, Woody and Kishore. I really must say that was an excellent presentation and discussion from you and from all the panelists. And with the permission of our president, Dhiren, I think we can close the session right now. And if there's
Yes.
any closing remarks you'd like to make, Dhiren?
No, but I would just like to thank Kishore and Woody for that. And I would say namaste. Thank you.
Thank you so much, guys.
Thanks,
Bye.
guys.
The opportunity is really wonderful. I'm sorry we went too long for the no cases. I apologize.
No problem. Maybe we can do part 2 again because there's so much of stuff remaining. Maybe we could just do case discussions and follow up to this webinar.
That'd be fun.
Yes,
I would love that, where why don't we all submit 2 cases and just discuss around the cases would be fantastic.
So we have a good collection already because everyone has sent in a couple of cases. We have about 7 or 8 good cases. Maybe the next time we could fix up at your convenience and do just case discussions to follow up on what we've discussed today.
Alaric, I think we ought to do the cases. It's very important.
Sure. Great. So thank you guys again for joining in, and have a great weekend.
Thank you.
Thank you, guys.
Bye, everyone.
Thank you. Stay safe. Thank you.
Thank you.